Awesome. Thank you, Teresa. Thank you, Tiffany, for a fantastic talk. I know you're probably a little tired. You've been sitting a lot today. This is going to be a brief lecture, and then we're off to lunch, so I don't want to keep you from lunch too long. However, this is obviously a critical topic. We've raised it a few times over the course of the last day or two, but I do want to dive in just a little bit deeper to talk about health disparities as we've described them here. Now, whenever I use these words, some people get uncomfortable, and that's okay, because these are topics that people, I've often said, it lands in the 3 Ps. People can look at this topic as being personal, professional, or political. Let's take the political part out, not that there's any politics going on in the country or anything at this point. Yeah, awkward, party of one. Anyway, we'll take the politics part out of it and think of it as both a personal and professional phenomenon. And so when we talk about health disparities, I tend to like the CDC definition. There are different ways we define this concept, but I'll read this to you. But they're preventable differences in the burden of disease, injury, violence, or opportunities to achieve, notice the word, optimal health that are experienced by socially disadvantaged populations. So lots to sort of unpack there, but the key words are that are preventable, that we want to have people achieve their optimal health, and this is experienced by socially disadvantaged populations. So it's not that there's some perfect standard of health that we want everybody to achieve. It's their individual optimal health. A little bit like yesterday when someone asked me, what's the standard of care in myeloma? It's hard to say, is it a triplet, is it a quadruplet? I mean, it really depends on a lot of scenarios. And similarly, when we think of health disparities. And so that's the disparity. We overcome it by seeking health equity. What is equity about? Well, it generally refers to individuals, again, achieving their highest level of health through the elimination of those disparities in health and in health care. And so I can argue, I'm giving a talk in a few weeks in Charlotte to a group of physicians. There's an organization of physicians in Charlotte that was created actually 90 years ago, actually when black physicians were not welcome in the usual organizations in society, which is a terrible mark on our history nonetheless. But the title of my talk is Multiple Myeloma, the most disparate cancer in the African American community. And how can I use that word? I use that word because we look at all the different cancers, there's different disparities in different ways, but a black man or a black woman diagnosed with myeloma today is expected to live half as long as the exact same aged white man or white woman with myeloma. And hopefully we'd all agree that's totally unacceptable. Now, that's not all myeloma related. There are other things that influence mortality, but that is clearly unacceptable. And that's more dramatic in myeloma than any other cancer, specifically within the African American community. I'm going to be focusing a lot of our discussion within the African American community because that's where we see the greatest disparity. But we see disparities in other places as well. Within the Latino American community, there are disparities based on age, based on gender, based on geography, based on orientation. There's a lot of different ways that we can cut the disparity concept, but I'm going to be focusing primarily within the African American and Latino American population because that's where we see the greatest disparity. I quote my daughter when I asked her when things became so much more aware within the society with the Black Lives Matter movement. I said, honey, how do you deal with someone who says to you, Black Lives Matter? Don't all lives matter? And she says, well, of course all lives matter. She says, all the houses on our street matter, but when one of them is on fire, we need to do something about it right away. And so we have lots of houses sadly on fire within the myeloma disparities world, but there are a few that are particularly lit up that we want to address. So what has caused this? And again, I'm not going to give you a long talk on drivers of disparities, but I always start with these top 3 because if we don't look at these top 3 and we just dive into the myeloma specific ones, we lose the bigger picture, that there are issues within racism, within the healthcare system, the key social determinants of health. Teresa shared with us this great talk yesterday on shared decision making. It's hard for me to have a conversation about my patient about whether or not they want a triplet or a quadruplet or they want a transplant or not or a clinical trial or not if they're hungry, right? If they don't have the basics of life, right? And we're spoiled here in many respects when we have these patient family seminars in cities where people tend to have opportunity. But we host a lot of these meetings, and there's a strong purpose about the way we feed you this weekend, not just because we love to eat, but because we know that there are people that come to these seminars where this is going to be the only 3-course meal that they're going to get in the course of that week, and we want to make sure people are fed. So our health is very much influenced by our housing, by our food, by the security that we have in those areas. People who live in what we often think of as grocery deserts or food deserts, where people don't have the opportunity even to get the kinds of groceries that you and I take for granted when we go. I know my wife thinks I'm addicted to Costco and addicted to the grocery store because I like to buy my own fruits and vegetables before I cook them. And we do like grocery shopping. A lot of people just don't have that opportunity. And so those things always have to be encoded in our thinking of why there is a disparity. But now I'm going to drill down a little bit into the myeloma specific ones. There are things that are specific to myeloma that drive these disparities. The biology of myeloma, and again, I'm not going to nerd out or geek out on you as I promised earlier, but as we've said so many times this weekend, myeloma is different in every person, but we've generally divided people into high risk and standard risk myeloma. When someone hears my opening statement about the difference in survival between black patients and white patients, for example, they might say, well, perhaps it's a little bit like prostate cancer or some other diseases where black patients are more likely to have a more aggressive form of myeloma. That's actually the opposite in myeloma. Black patients are actually less likely to have high-risk disease. They're more likely to have translocation 11-14, which there was some discussion earlier, which is generally a favorable prognosis. So we can't blame it on biology, but there are so-called concomitant diseases that confuse the picture. Myeloma, when it comes to myeloma, for example, I always say that diabetes is a great challenge because diabetes is the great mimic, right? We have a lot of our patients eventually diagnosed with myeloma who for many years have been told, or many months, have been told, oh, your anemia, your proteinuria, your renal insufficiency, your neuropathy, it's all from your diabetes, when in fact they're brewing myeloma the whole time. And so often the diagnosis delay, which is driver number 5, is delayed because of that. That's why I mentioned yesterday, the average patient sees their primary care provider 3 times with signs and symptoms consistent with myeloma before the diagnosis is sought after. And many of you have already shared unfortunate stories with me since yesterday about the delay in diagnosis that there was. That delay is averaged 3 to 6 months longer if you're African American or Latino American. And some of that has to do with diabetes, some of that has to do with lots of other access to healthcare reasons and diagnostic reasons, but that becomes a big part of the disparity, something that we really want to focus on. And so, for example, as I'll share with you what we're doing with our Empower program, we're about to launch a program in inner city Detroit in diabetes clinics where we're going to start to more vigilantly look for myeloma because we think myeloma has been underdiagnosed in that population. So the delay in diagnosis is important. And then I often call the access to the key therapies that have changed myeloma. You know, Dr. Loniel and I shared earlier our future look at myeloma. If I look back at the last 20 years of myeloma, and we have some myeloma doctors here, of course, that have been doing myeloma for a long time, I would suggest that there have been 4 major movements that have significantly improved survival in myeloma, and they all start with the letter T, which makes it easier for me to remember. Triplets, or 3 drug combinations, now moving towards quadruplets, as we've said. Transplants, or autologous stem cell transplants, clinical trials, as Yellick and I shared yesterday, and then most recently CAR T-cell therapy. Sadly, we've shown for all 4 of those, there are certain populations, socially disadvantaged populations based on our definition, who have had less access to these 4 things. And so it's no wonder that their survival and the outcome has been reduced. And then lastly, number 7, put it on us as the providers that we don't always reflect the cultural sensitivity and competence that we should. We may not be sensitive to these kinds of things. We may not be aware when I'm in clinic that there's a lot more to someone than just their plasma cells. As we've said so many times, we don't treat myeloma, we treat people. And so us being, as healthcare providers and teams, more aware of these and more willing to support people through this journey is really important. And so we'll share with you a little bit about what we've been trying to do to help overcome that. So the fast facts are here. I can go into a lot of detail around them. I won't. Most of this has come out over the last day. but there's a longer time to diagnosis. African American and Latino American patients are diagnosed at a younger age, which is also part of the delay because, medical school, when I went to medical school, you're kind of told that myeloma is a geriatric condition, right? Little do we know that it can happen in much younger. I traveled once to Uruguay to visit what we think is probably the youngest person ever diagnosed with myeloma. It was an 8-year-old boy. Poor pediatricians don't know how to spell myeloma, right? They don't treat myeloma. So that's extremely rare, of course, but we do see a huge age range of myeloma, and we all have patients in our practice in their 20s and their 30s. But on average, it's diagnosed younger. We've already mentioned already it's twice as common, less access to the 4 Ts, more likely to have lower risk features as opposed to high risk features like P53 deletion, and that the survival outcome, as we said, is half. But number 7 here is particularly important to me because it proves to us that we can do better. So when we look at the VA system, and albeit not a perfect system, at least theoretically in the VA system, independent of your race or ethnicity, you have the same access to the diagnostic and therapeutic pathway of care. So when we look at studies within the VA system, it's ironic that African American patients actually do just as well, if not better, than white patients. So it tells us that when given equal access to diagnosis and therapy, we can have an equitable outcome. But obviously, that's not what we experience in society at large. So what did the IMF do? Well, we've created this program. Sylvia made mention of it. It's come up a few times today, of what we call Empower. It's a bit of a play on words. M standing for myeloma. Power, we're wanting to empower patients and communities to change the course of myeloma. That what I've shared with you up until now, hopefully you have a bit of discomfort in your stomach saying this is not acceptable. Independent of what race or ethnicity you may have yourself, that this is not acceptable. I don't think it's fair for people to have such inferior outcomes with myeloma. And so we want to reverse that, and we want to improve the short-term and long-term outcomes of African American patients and all patients with myeloma. Going back to the burning house analogy, we're committed to every patient. The I in the IMF, as I said yesterday, was international. We want to help every patient in the world, but there's clearly disadvantaged groups. And so we did this based on this 3-pillar model. So we have 3 major aspects of our work. Number 1 is to engage the community. Partly what we're doing here, but we'll show you events and things that we're doing where we go right into the community. We're trying, I know I sound so simple when I say this, but trying to break the way of thinking that we've always had, that I only interact with the healthcare system when I'm sick, right? I'm sick and I go to the hospital or to the clinic or to whatever. I'm trying to have us as a healthcare system realize that we need to proactively be in the community to promote health, to engage the community, to build that kind of trust, so that when that person is sick and they do have to come in, there's already a relationship built. It's not always a one-way street coming into the clinic. And so we believe community engagement is important. As I'll show you, we'll engage with everybody and anybody in the community. We do programs in churches, fraternities, sororities, community health centers, you name it. We'll work with anybody and everybody. We've worked with the National Medical Association, with the Black Nurses Association. We work with anybody to embed ourselves into the community, do projects, do seminars. Dr. Shaw was with us just a couple of weeks ago. I'll show a picture where we did a program around Juneteenth in Harlem at the Abyssinian Baptist Church, and she gave a talk on nutrition. It really wasn't even really about myeloma. I gave a talk about blood. I talked about sickle cell disease and just what blood means within the Black community. And of course, we talked about myeloma, and Yelek shared his story as a myeloma patient, just so that we can build that trust and raise awareness of myeloma in general. Part 2 is educate. If the delayed diagnosis is a big problem, we want to educate the primary care physicians. Because by the time you see Dr. Joe or Dr. Shaw or Dr. Fonseca or Dr. Dispenseri, I mean, the diagnosis has already been thought of and already been worked up. But it's at the level of the primary care that we want to help primary care doctors know when to think about myeloma and what tests to order so that they can facilitate that diagnosis more quickly for all patients, but in particular those patients that are at higher risk of delayed diagnosis. And then lastly, to enhance the care of the patient who is being treated for multiple myeloma. So that's affecting the whole healthcare team and their cultural sensitivity and competence, affecting the access that patients have to care and facilitating that. So all the projects, everything that we've done, whether it's, as I've mentioned, engaging in a community or educating a primary care doctor or enhancing the care, they're all under the umbrella of our Empower movement. And Empower has been both local and national. We recognize that no two communities are the same. And we don't just do a cookie cutter approach and saying, oh, Baltimore is the same as Atlanta, which is the same as Detroit, which is the same as Charlotte. We recognize that every community is different. And so we go in and we build connections within the community and do programs that are specific to that community, but also provide resources nationally. So to give you a flavor, we've gone to different cities, as you can see here, like Charlotte and New York and Tampa and Detroit over the last couple of years. We do Facebook Live programs. Sorry, my face is everywhere here. But we do programs where we try to connect with people in different ways who have access to the internet. We have to do programs to remember that there's some people that don't have access to the internet or may only have it through a phone, and making sure that we do it in a manner that's comfortable for them. We've done a lot of work, as I've mentioned, with educating primary care doctors, creating these little pamphlets that simplify what are the signs and symptoms to look for and what are the key tests to order, doing programs. We just did a program a couple of weeks ago, or last week, at the annual meeting of the National Medical Association, which many of you may be familiar with, historically known as the Black Doctors Association. They hold an annual meeting, and we did a program directed towards primary care and those who are on the front lines to be able to diagnose it more quickly. We've also tried to affect the scientific and medical community. As geeks and nerds as we are, we read papers all the time, and so we want to be able to have publications that will allow people to understand, and the physician community and the nursing community to understand it better. One of my favorite programs, as I come almost towards the end here to share with you, is a program that we've done with medical students called the Medical Student Scholars for Health Equity in Myeloma. So what we've done is we've reached out to medical students, most of them from historical Black colleges and universities. So places like Meharry and Morehouse and Howard, and we've paired these students, and you might recognize some of the pictures of the doctors next to them. We've paired these students for 6 months to do a project in health disparities related to myeloma. So we've given them the opportunity to cover any topic that they wish within that umbrella, so that they can get experience in doing research. For most of these students, it's the first research project they've ever done. But it's an opportunity for them to learn about myeloma, to learn about health disparities. Of course, I want all 12 of them every year to become myeloma doctors, but whatever they become, we want them to be sensitized to myeloma. If they become a primary care doctor or a cardiologist or a surgeon or whatever else. And at the end of the 6 months, we bring everybody together, and we just did this last week. This is some pictures from last year because it was so hot off the press, but we brought everybody together at the National Medical Association annual meeting, and each student presented their project as a poster. And we had a poster walk. Beautifully, last year we had a whole series of people joining us in the poster walk. Some of you may recognize a dear woman there, Dr. Edith Mitchell, who is on our board, who sadly passed away this year. Just an incredible woman and pioneer in the field of health disparities. But these students were unbelievable. I mean, just speaking from the posters that were presented, Dr. Shaw was with us last week in New York City. It was just overwhelming what these students were able to do in such a short period of time. And so we hope no matter what field, as I mentioned, these students go into, that they're always going to be sensitized to it. So we've tried to provide resources, and Peter's here from our marketing team has been so helpful to us in building a website and creating resources for people to help them in multiple different ways and understand how myeloma affects their community with tremendous social outreach. And going out into the future with our Engage, Educate, and Enhance, we're going out to multiple other cities, and actually going out in 2025, we're going to start to create programs within the Latino American community with our first planned in Miami next year and the region there. So just to leave you another picture, this was the program we did just a couple of weeks ago at the Abyssinian Church in Harlem. It was such a privilege to be there and to engage with this community. I even brought my 2 daughters with me who had a chance to learn a little bit more about what Padre does. So what do I leave you as some takeaways today? Health disparities really are prevalent across all diseases, but particularly, as we've mentioned, most disparate in multiple myeloma. There are other types of inequity, there's no doubt, but I focus today within the African American community where the disparity is the greatest. And it's hopefully giving you a sense of the bigger picture here, also of what the IMF is trying to do, and hopefully engage you to do this. If you want to be involved with us, we have a special little table even out in the foyer here that you can come and see Joy, who works with us. Joy Tisdale is my partner in crime and Empower. We even have a little bit of Empower merch, I think. There may be some fanny packs or hats, or if not, we can order one for you. But we want you to be aware of the program and what we're trying to do to reduce these inequities. And going forward, what can you do? Hopefully be more aware of this, that just listening to what I've said over the last 15, 20 minutes will sensitize you to the issue and think of the opportunities and support the Empower movement in whichever way you want. You can go to the Empower website, read more about it, learn more about what we're doing, especially if we're coming to a community near you. We would love to have you engage with us as we go forward.